Good morning. Today we're going to take the opportunity to go over an enhanced daily skilled note. And you will see that inside PCC labeled just as you see it here, Daily Skilled Note PDPM. This will become effective with April 1st admissions and readmissions so that it will automatically fire based on those payers. And we will then need to continue to do those notes every day just as you have been doing with the current note. We will not retire the old note for approximately 30 days, so you will still see some of the old note activity based on patients that are currently in the building already, because the new note will only start with the April 1st admissions and readmissions and then carry forward from there. So you may not start to see the use of this note in practice for a couple of weeks after April 1st, depending on what the level of your admission activity is. So again, this note is very similar to the one that you're currently using, so there's not a lot of new features to it, but there are some added things that are there, and it was an opportunity to go through and provide explanation about the note, the intent of it, some tricks within the note, and it was really developed to try to allow you to get some of the information you need for the note while you're in the note, as opposed to having to flip-flop around inside PCC. So just as it does now, you will see that there is the full set of vital signs that are showing up when you have the note open up each day. So it's going to have the full set of the most recent vital signs that are there, and that's what it's telling you, it's the most recent. But if indeed you wanted to take a look and see what all of the other ones have been, you can hit view all, and you would see then the history of that particular vital sign. So this one would be the weight, this one would be the temperature, this one would be the pulse, and so on. So this helps you when you're trying to figure out if something has changed between the last time you worked or between yesterday and today, for you to be able to use that in consideration for completing the rest of the note. So currently, as I show you this, I am in the management side of PCC. So you do not see a patient's name. And unfortunately, as I show you some of the things that you can do, it won't pull up a patient's information. And that's specific because we were recording this and we didn't want to have any HIPAA violations in the process of doing that. So I'll talk to you about that when we get to those particular areas. So now we start off with skilled diagnosis, and that's the same as your current note right now. It's telling you that if you have a new or resolved diagnosis, then we would need to have this edited in PCC. And currently the MDS coordinators are the ones who add and remove and allocate an assignment, a ranking, if you will, to the ICD-10 codes that are in PCC. You can use the eyeglass and it will pull up all of the patient's current diagnosis, and then you can select from those diagnoses or choose all of them. If you have a new diagnosis within the last 24 hours, you would put a check mark here, and you will immediately see a prompt that comes up that tells you that you should discuss this new diagnosis with your MDS coordinator. Okay, because there are opportunities to improve revenue and reimbursement based on some new diagnosis. If you don't put that check mark, you won't see the prompt. If you resolve a diagnosis, equally important to talk to the MDS coordinator and the business office manager so we can make adjustments inside PCC about which diagnoses are still current and active for the patient. Anytime these prompts come up in red, those will not show on a printed report. So if you were to print this after you completed it, you would not see these prompts that are showing up for your benefit. Okay, so you're not going to see a note that has all these types of things on there. Then we move on to the management and evaluation of plan of care. So this particular area of the note is specific to the fact that you've evaluated or revised a care plan based on either order changes, doctor's visits, or perhaps some sort of a meeting that was held in the building or an incident. So someone fell and now maybe you're having to deal with the fall and the ADL and a pain care plan. The doctor came in and changed added a new consult about something or gave us some new orders. So you may have more than one of these things that checked off. You attended a standard of care meeting or morning meeting and you heard something at that point that was going to require some care plan update. When you check off any of these boxes, order changes, it's going to ask you what is the order change related to. You are not expected to rewrite the orders here. If you got a new medication for pain or a new medication for an antibiotic, all right, so then it would be related to infection or pain. If you got a new order for a diet or a supplement, then it would be nutrition. Very simplistic words that are basically going to tell you this is what the order was related to, and therefore you should expect to see that you have to look at some care plans related to those new orders as well. So if someone has infection, it may be, depending on where that infection is, maybe we're looking at a sepsis care plan. Okay, maybe it's a urinary tract infection and we're looking at the elimination care plan. Maybe that infection is causing some change in mental status, so we would be doing cognition. Maybe that infection is making the patient exhibit moods or behaviors, or their pain is causing them to strike out at you and there's mood and behavior. So based on what the orders or the doctor's visits were, you should consider what care plan items would need to be reviewed or revised related to this. Okay, and if there were no order changes, visits, or other things that happened, then you would say none of the above and no additional questions would open. Then we would move on to observation and assessment of patient of care. And for this particular area, this is the bulk of why someone ends up being skilled under a Medicare benefit. Okay, yes, we can do it for management and evaluation of care plan. Yes, we can do it for therapy, but a good portion of why someone is here in a nursing facility is that they have additional risk factors or comorbidities that require us to observe and assess this patient for changes in condition. There is this prompt that again will show up, and it will not be on the printed report, but it's telling you to refer to your daily documentation guide. So right now, every single day, there's a meeting held that we discuss all of our Medicare patients, and that is updated. When it is updated, it updates a tool that should be provided to all of the nurses that identifies for you what you should be documenting on. So some of the facilities have chosen to have an area that looks like this on the tool you get that tells you these are the 3 things that you should be opening up for your daily note. You may open more based on something that happens that particular day later on, but minimally, because of what we are skilling the person for and the discussions we're having through that morning meeting, we expect that your daily note would mimic some of the areas that we're focusing on. So you should be getting this every day already, and if you're not, you need to have a discussion with the director of nurses to find out how it is that you get this note consistently so that you can use it to document your note. Okay, so now you're in observation and assessment. It's telling you to refer to that daily documentation guide that you will get. And then you will notice that you have all of these different areas of systems that you would be observing and assessing the patient for based on their diagnosis and other things that might occur while they're in there. If you are to look and see cardiac or respiratory right now without any check marks in them, you will only see symptoms of trouble. So what this is that maybe a patient isn't there primarily for their cardiac problem, but they develop a cardiac problem while they're in your care. Just because we weren't skilling them for that doesn't mean you shouldn't be mindful of the things that would indicate that there's a cardiac issue developing or being exacerbated. So even if you haven't put a check mark here, we're trying to identify for you symptoms of trouble so that if you see one of these things, then whether or not we've asked you to put a check mark based on that documentation guide, if you see these things, then good standard of care would be for you to then put a check mark in there. And then it will open up a full assessment for whichever you put the check mark. So now you see the cardiac there. Okay, so you would go through and you would answer these questions that are specific to cardiac. The same thing would happen for respiratory, GI. So as it stands right now, if you don't put a check mark, all you see are problems related to that system. The minute you put a check mark there, it opens up the assessment. So for the purpose of training, I'm going to open all of them so that you can see the questions that are there when a check mark is present. Okay, so then what we've tried to do is that when you answer something early on, so let's say you answer a question for cardiac and it's relevant to respiratory. You answer something for respiratory and it's relevant for infection. You answer something for respiratory and it's relevant to skin. If you answer it somewhere early in the assessment, we're having some things pre-populate for you. So for instance, if I were to check off for cardiac, the skin color was pale. And I go down further into the assessments where there's other questions about skin color, pale is automatically checked for you. So you don't have to recall or perhaps miss these things. Now, the only thing that I would caution you to is that when you put the check mark in and it automatically populates in other places, if I were to go back and take that check mark out up at the top, it would not remove it from here. So that's the only thing you have to be mindful of. If you make a mistake when you've checked something up above, then you're going to have to take it out of the places that it populated. And you'll know that something has populated by this little blue check mark next to the question. Whenever you see that, you know that the answer that's there came from another place within the note. So again, we're trying to make it so that there's not duplicate efforts and we can speed this note along and have it accurate. The same thing would happen with edema. If you check off that the patient has edema, it wants to know the location and it wants to know, is it pitting, non-pitting, dependent, new, or worsened. So if I were to say it was non-pitting and it was new, then if I scroll down to other aspects of the note that ask me about edema, you would see that it already answered it. Yes, it's non-pitting and it's new. And you know that that answered because the blue check marks are next to it. All right, so again, if I went up there and took that out, then it would not remove it from down below. All right, so as you're looking at this and you're going through, we're really trying to figure out, so is there cyanosis present? All right, we're going to say no. You can free text what someone's activity tolerance is. Pain presence or absence, okay? So again, we already know the pain because up in the vital signs, you have the pain, whether or not there's a presence of it or not, but we don't know where it is. So you can put down where it is here. Capillary refill, less than 3, distended neck veins, I and O. If you say yes, it now wants to know what is the intake and the output. Well, there are other aspects of the note that will ask you if intake and output has been monitored, and it will automatically populate for you. However, it will not take these amounts that you put in and carry that forward. It doesn't have the capability or the sophistication to do that. Is there an alteration in respiratory status? And so you can say yes or no to that. And it tells you to refer to the respiratory assessment. And the only reason that that was automatically there is because I put check marks in all of those areas up top. So you have respiratory going through trachs and mechanical ventilation, oxygen use. If you say yes, now it wants to know what's the liter flow. You're always going to get these two questions about whether or not a resident avoids lying flat. This is one of the new features to the note, and that specifically came from concerns where MDS coordinators felt uncomfortable with coding on an MDS that someone was short of breath, lying flat. They were concerned that there wasn't a note necessarily that said that in the look back of their MDS, despite having identified it on an admission eval, having it in a care plan. Once we've identified that someone is short of breath lying flat, no one is expecting you to every day go back to the patient, lower the head of their bed till they turn blue so that you can document that they're short of breath on laying flat. All right, no one expects that. Once you identify it, we should then be putting things in place to promote respiratory status when they're in bed or alternate sleeping furniture. So you'll see that we put those questions here. So does the patient themselves avoid lying flat because they struggle with it? Is the head of the bed up slightly? Do they have pillows? Do they lean forward and have an orthopnic sort of positioning when they're sitting up? And then our interventions in place to promote that respiratory. So you want to indicate it might not be applicable. Maybe the patient doesn't have that problem, shortness of breath. All right, and then this is for the note, shortness of breath during your shift, during the last 24 hours. Have they had shortness of breath with exertion? Have they had it with rest? Or at the time of your note, there is no shortness of breath at the time of the note. This says to us, they don't have it now. Doesn't mean that they don't have it, and they won't have it an hour from now, 3 hours from now, in the middle of the night. So if we had the note and it pigeonholed us to just say no shortness of breath, when you send that out on appeal, keep saying, look at these notes say no shortness of breath, no shortness of breath. This is saying, no, they don't have shortness of breath at the time I did the note. That doesn't mean that there weren't other episodes of shortness of breath throughout the day. Do they have a cough? If you say yes, then of course it's going to ask you, is it productive? Were nebulizer treatments given in the last 24 hours? So if you say yes, now it's going to tell you, verify that you've got the correct order set with supplemental documentation in place. So we've been struggling with being able to capture the licensed care that you're giving on our MDSs and then being reimbursed for that care simply because we don't have the right paperwork. You should have an order that has supplemental documentation, and those have been put into PCC, and you should make sure that the right one has been chosen. What were the lung sounds before and the lung sounds after? What's the respiratory rate? Again, you see these things already filled in for skin color, edema, and then we move on to GI. So what I wanted to show you is that some of you that are new to PCC or even old to PCC and weren't trained in these things, the H's allow you to look at how this question was answered historically. So right now, if I hit it, there's going to be no history. And there won't be a history for you for the first couple of days because it's going to be comparing this note to other notes that were done previously. And this is considered a brand new note as of April 1. So on April 1, if you used an H, you would not find any data. But on April 2, when you go and hit this H, you should see how this was answered on yesterday's note. So that can sometimes help you to determine whether or not this is new, whether this is worse, whether you need to do something or expect that someone else already has, what we need to communicate. So you see again that when we had put I&O up top, you can see now that the I&O is already checked here, and you know that that came from somewhere else because you have the blue check mark. The other thing you have available throughout this note are these blue question marks. When you hit that question mark, it is going to show you CNA documentation related to that question. So this is about bowel characteristics, the color, the size, the inconsistency. When you hit this question mark, it's going to show you in the last 24 hours whether they've had a bowel movement and what the consistency of that was, provided your CNAs documented. They need to be compliant with the documentation in order for this to work for you. So this, again, is a way for you to, when you're hitting question marks and you can't find the data you're looking for, that's your first indication that staff are perhaps not compliant, because this will look back for 24 hours. So it's not just your shift and maybe they haven't gotten to it yet. All right. Nutrition and hydration. It's always going to ask you if there are documented symptoms of swallowing problems in the last 24 hours. And again, you have a question mark so that you can see what the CNAs have coded. And you have the H so that you can see if they have swallowing problems now, did they have them yesterday? Is this new? Do I need to communicate this to someone? Do we need to have a referral to speech therapy? Does the dietitian know? Who do we have to get involved? Meal intake, a question mark and an H. So you can go back and see in the last 24 hours, what has the person's intake been? Again, you will see that I&O has already been checked in this particular part of the question so that you don't need to do that again. And then whether or not their fluid goals were met. Skin integrity. Here's that edema that we had marked somewhere up ahead. Okay, you know that that's the case because you have that blue check mark. Pressure ulcer, yes or no? If you say yes, now it's going to ask you, is it new or worsened? And then they want to know where is it and any information about it. Surgical site, yes or no? Wants to know where is it? Diabetic ulcer, yes. Where? Vascular wound, yes. Where? Appearance. Even if someone only gets a wound vac changed every 3 days, that does not mean you don't have to assess the wound. You're not necessarily doing the wound bed, but you're assessing the healing, the potential for infection. So you're looking at the surrounding skin, you're feeling for the temperature, you're looking at the intactness of the dressing that's there and the integrity of that dressing. So just because you only do wound vac Monday, Wednesday, Friday, that doesn't mean you skip this part of the note because you're not changing the dressing. All right, you're assessing the patient for a vascular wound. You're assessing the patient for their diabetic wound. You're not just assessing the wound, okay? Pain. Do they have complaints of pain? If you say yes, then it's going to open up this body and ask you for the pain and to describe it. If you say no, then that body is not going to open up. Urinary characteristics. Here's that I and O again that's automatically there. Did not void. They had frequency, urgency, hesitation. Again, here's an H, and it will show you the historical answers for that question. Mood and behavior. Has the resident exhibited mood symptoms? Question mark. So now, over a year ago, we opened up mood documentation to activities, social service, nurses, CNAs. Basically, anybody could go in and document if the patient exhibited some sort of a mood symptom. So the CNA documents this morning, no mood. 10:30, 11 o'clock in the morning, no mood. They go through and document it. 2:30 in the afternoon, the activities person has to escort this patient out of the room because they're crying uncontrollably. They then would be expected to go into PCC, hit PRN documentation, and put in that crying episode. All right? That's what you should be able to see. You may or may not have that level of documentation going on at your building, but that is the expectation. And minimally, when you hit this question mark, you'll have what the CNAs put in. Have they exhibited behaviors, yes or no? Muscular skeletal. So we have edema, weakness, mobility. Yes. Where is it? Do they have a cast, capillary refill, temperature, movement? So if I say yes, oh, all right, well, there's 4 questions there. What am I saying yes to? Did I look at their capillary refill? Did they have temperature, change in temperature? Is there a problem with the movement? And I don't give you anything to put here. This would be an example of saying yes and then needing to go down to the summary to elaborate on what it is you were concerned about or what it is you assessed related to a cast. Changes of range of motion, same thing. If I say yes, you're going to, in the summary, have to tell me where those changes are. Neurological. Does the patient have a current neurological diagnosis? All right. So if you say yes, then it's going to open it up and show you what is it. All right. CP, MS, Parkinson's, TBI, CVA, TIA, stroke. All right. So you can pick that. Did the resident complain of a headache? If you say yes, now it's going to ask you, all right, in addition to that headache, did they have nausea, vomiting, dizziness, change in vision, or no other symptoms with that headache? Because those can be indicators of a change in a neurological condition. All right, so I'm going to say none. Is there a change in the patient's communication? Yes. Now it wants to know, where is that change? Do they have a change understanding others? Do they have a change being understood by others, or do they have a change in both being understood and able to understand? All right. Was the resident incontinent in the last 24 hours? Question mark will allow you to see for the last 24 hours whether or not the patient was incontinent. So now you're able to make the answers to these things be more reliable and still be efficient in the fact that as long as your CNAs are compliant with their documentation, then you are able to get through this note relatively quickly with very solid background and supporting information. And when you can't with the question mark, then you guys need to start talking about, all right, why are the staff not compliant? We need to be compliant so that we can use that data to make our decisions on how it is we care for the patients. That's what their job is. Okay. Has there been an increase in incontinence? So you can take a look at that. It's not increased. Is there an increase in muscle weakness or loss of movement? Yes or no? All right. Did they exhibit any repetitive or involuntary movements? You can say yes, and then it's going to ask you to describe it. Has there been a change in their memory? And if you say yes, again, you may need to elaborate down in your summary because there's nothing else here. Now we move on to teaching and training. And a lot of times people put stuff in here and they'll say, yes, we're teaching and training the patient, or they'll say not applicable. And honestly, teaching and training is somewhere where we fall short as an organization, as an industry. All right, we don't take the opportunities to take credit for the time that we should be spending in teaching and training the patient and the caregivers, the family members. So you want to do this just like discharging. Teaching begins on admission. You shouldn't have somebody there for 3 weeks, and now therapy says, oh, well, I can't work with them anymore. And now we say, oh, well, can we teach them about their diabetic status? No, that should have all happened from the beginning, and you should have been building towards having them master whatever it was you were teaching by the time that therapy was going to be done as well, so that perhaps when they're discharged. When you're not good at this, when you don't take advantage of this, then it's difficult for you to demonstrate that as a nurse, as a facility, that you did everything that you could possibly do to keep that patient from being readmitted to the hospital after they left your care. All right, and so this would be the first indicator when you're saying that there was no teaching applicable, or when you say it's applicable, which some people do, and they'll say, oh, it was ongoing education to the resident. And then you know what they put over here? The patient was reminded to use call bell and told to call the nurse if their wound vac is beeping. That is not education. That is not something that would keep them from being readmitted to the hospital. It's not something they can carry forward. It's not something that you could measure and that you use different tools and items for and able to follow up on. I will send to the directors of nurses a template for teaching and training, because you should be identifying what's the problem, what's the knowledge deficit, what's the barrier to the patient doing it, what medium are you going to use for the teaching, how does the patient respond to the teaching, and what's your overall outcome. Were they successful, or do we need to abandon it? And now that becomes part of a concern for discharge planning. If they can't manage their diabetes in your setting, then we need to make sure that in the community, there's someone that is able to assist them with that. Okay, but you need to identify it first, then you need to address it, and you need to follow through with it. So I see non-applicable a lot, all right, and really it probably is more applicable than not. Now, if someone's there 30, 45 days, you may have completed all the teaching, so it's no longer applicable, and that's fine. But don't just go through and say, oh, it's not applicable, or worse yet, don't tell me it's applicable and then tell me that you told them to call you when something's beeping or to use their call bell. That's not teaching and training. That's just safety protocol. Then you have your direct nursing skill. All right. And so we don't expect that nurses know all of the Medicare rules about what constitutes a direct nursing skill and what does not. So if you are uncertain, if you hit applicable, it will show you what those areas of skill are. So now you see IV meds, IV fluids, an infected surgical wound, multiple pressure areas, a single stage 3 or 4, someone being on a tube feeding, IM injections, a new ostomy, a trach or a vent. So if you don't have any of those sorts of things, then you can say not applicable. Direct skilled rehab. All right. Again, people will say not applicable and they're on rehab. All right, it's important for you to know when people are on rehab, because you need to know what they should be doing on the unit when they're out of the gym. So if you say applicable, it wants to know, is it PT, is it OT, is it speech? Again, you have H's in every single question that will show you historically how something's been answered. That's not meant for you to use so you can copy from yesterday what the answer was, okay? We need to, and this is where everyone falls short, is we need to specify what's the carryover when they are on rehab. So it's great that when they're in therapy, they're doing everything for that hour in the gym and they're highly functional and really more independent. And then they come back to the unit and for 22 hours, they're laying there letting everybody else do everything for them. Because that's the way they're going to go back home. That's the way they're going to be at home. So you need to make sure that you're looking at the carryover, that whatever is being expected to happen from a rehab standpoint, that you're aware of that so that you can promote that on the floor. If therapy says they can do a certain task, complete a certain thing, then you should know that so that your staff knows and allows that patient to complete that task. And then finally, you're left with additional information. So this used to be a summary and expected you to have, some information. I changed the wording a little bit. You will see this prompt that says to you, you only need to add information to the summary if you need to expand on areas that weren't covered in the note. So I told you that up ahead. If you can answer all of the questions as you go through it. Now, some people will come down here and write all this garbage. Alert and oriented ×3, bowel sounds present ×4, appetite good, no complaints of pain, family at bedside, tolerating rehab. We'll continue to monitor, which drives me crazy. You can't skip the whole bulk of this note and come down there and write that garbage. All right, you need to go through the note. You need to pick the particular observation and assessment systems that we're working on for this patient. You need to follow through with those assessments. And when you get down here, you really shouldn't have much left to write. And it says to you right here, based on the above assessments, the resident continues to require daily skilled services. Additional consideration is given to, and that's where you would put in any of this information. All right, so I will see that people put absolutely no check marks under observation and assessment up here in the top. They'll put no check marks here and then go down to that summary and write that nonsense. All right, that is not acceptable. And that was the intent of this note, was to go through and make sure that you guys understood how to do it, how to get information to help you do it quickly and accurately, and to make sure that there's no misconceptions about, what you needed to do down in that summary, or that you needed to write additional notes for people outside of this. This really should cover everything you need to do for your skilled patients. So again, this will become effective with admissions 4/1. I am assuming that all of the facilities will have conducted the education for the appropriate staff prior to that date. And I look forward to a compliant and a well-written note from all of you. Thank you and have a good day.